السادة الزملاء تحية طيبة. أنا الدكتور هشام فتحي، أستاذ طب الأطفال، كلية الطب، جامعة قناة السويس. في المحاضرة دي أنا هتكلم على genetic counseling as a starting point للgenetic disease. It's very important to know what's genetic counseling, what's needed to be done to do a rigorous genetic counseling, its indications and methods. learning objectives بتاعت المحاضرة دي. First, it's important to know what's to describe genetic screening and counseling. What's genetic screening and counseling? Explain the use of family histories in determining genotypes, what we call modes of inheritance. Discuss risk evaluation in genetic inheritance. Understand antenatal diagnosis for conditions which have a genetic basis. Understand postnatal screening for conditions which have again a genetic basis. Some of these, like genetic inheritance or mode of inheritance, we are going to cover it in more details in another presentation, but here I'm going just to give a highlight how important it is in the genetic counseling process. So what's genetic counseling? Genetic counseling, it is a communication process that deals with estimating the risk of developing or transmitting a genetic disorder. فدلوقتي احنا عندنا جزئين. الجزء الأولاني اللي هي possibility of transmitting genetic disorder to our offsprings. بس في جزء آخر مهم. Sometimes we have a late onset genetic disease like diabetes mellitus, like some of the heart disease, hypertension, or even Alzheimer, which have a genetic background. Do we need to know about it? If there is a possibility to know the risk of getting such a disease, all these are important in the genetic counseling. The objectives of genetic counseling is to provide those who seek consultation with the information to enable them to take their own fully informed decisions. So it's very important to know that we don't tell our patients when they come for counseling what to do. We just give them the facts and let them take their own decision. And to do that, we need first to diagnose if the disease they are coming asking for is a genetic disorder or not, what its prognosis and the possible treatment, and then what is the mode of inheritance. And it's important to be supportive and to have a good communication with our, you can say, people who are coming for counseling. What are the indications? There are many indications for genetic counseling. Some of them, which I'm just enumerating them here, like birth of a child with a birth defect. And this could be one of the causes that their families, they come asking the possibility of having another child with the same congenital disease. And then affected parent with a hereditary disease, like, as I said, diabetes mellitus. What is the possibility of transmitting it to your own children? Then again, it's very important part of what's needed in our new culture of prevention, which is a premarital counseling. We always ask new couples before getting married to have a genetic counseling to understand what is the possibility of having genetic disease, for example. Some of them, they are not only genetic disease, they can be even infections or others. What is a very important part of our work is to do premarital counseling. And then advanced maternal age. When we mean advanced maternal age, it are mothers more than 35 years of age. Why? Why it is important to ask for that? In many of the European and even North America countries, they offer antenatal diagnosis for those mothers who are having or thinking of having a child after the age of 35 because of the increased incidence of chromosomal aberrations among these women. Then consanguineous marriage, especially if there is genetic disease in the family or an important genetic, especially if it is an autosomal recessive one. Then recurrent spontaneous abortion, especially in the first trimester, as we'll know when we speak later on in another presentation about chromosomal aberration. More than 50% of the spontaneous recurrent abortions in the first trimester are due to chromosomal aberrations. And then exposure to known teratogens like drugs, radiations, or other factors that may affect their kids, and determination of paternity, which is again one of the important medical legal part that we have to face in genetic counseling. The principles of genetic counseling, that it is non-directiveness. Non-directiveness means that we don't direct those who are coming for counseling for a certain, a certain decision to take, which is again a very important medical legal part. It's very important just to give them the information and to let them to take their own fully informed decision. And then autonomy or self-determination, which is again a very important part for the families to take their own decision, not just telling them what to do. They have to take their own decision or after getting all the needed information about the possibilities of having a genetic disease or others. So the goal of informed decision making, first, preventing birth defects or genetic disorder and its potential consequences. So the responsibility of genetic counselor, first to consult or to show the possibility of having a prenatal and community education. So parental and community education, like good counseling for diagnosis and risk assessment, education, and helping them in taking informed action. Then provide options, and these options are either reproductive, possibility of having a diagnosis, either antenatal, natal, or postnatal, and what are the management available for this genetic disease. And then it's important again for us to give education about infant screening, rescreening and its timing, proper sampling, specimen handlings and transport, demographic data collection, and target screening for high-risk population. And because sometimes it is not that a certain population are at risk of getting infectious disease due to the presence of hazardous, you can say, substance like irradiation or even high voltage lines, electric lines, or even certain chemicals in the area around that. So all these are very important to discuss it with the community at large. So we have 5 steps in genetic counseling. In genetic counseling, we start by diagnosis of the genetic disorder. And in diagnosis, as we know, it has 3 main elements, which are first taking medical history, then having a thorough clinical examination, and then look or ask for specific investigations to confirm our diagnosis. So first we have to know if the condition that those who are coming for consultation is actually a genetic disease, yes or no. And then look for the risk of recurrence. So it's what we call risk assessment. So whether it is a single gene disorder, like autosomal recessive, autosomal dominant, X recessive, X dominant, or others, is it a chromosomal abnormality, or it is even the most common one, which is a multifactorial disorders, which is composed of multiple factors or multiple genetic or gene defects plus effect of the environment. We are going to speak about that when we speak about modes of inheritance. And then if we have either environmental etiology like specific teratogens and infections, especially viruses and others. Then we provide options for those who are coming for consultation. And options will be reproductive options, then diagnosis. If we have a diagnosis for this case, either prenatal, postnatal, if there is a screening program to diagnose this case earlier, and if we can even diagnose for carriers by examining both parents. And what is the management options available? And then choosing action based on, as we say, the action will be taken, or the decision to have an action will be taken by the family itself. So it will be based on recurrence risk. What is the risk of having another child or another person with the genetic disease, the disease burden, how large a disability, if there is psychological or economic burden that will be needed to cover if we have a child with this abnormality. Then family goals, because sometimes family goals will affect our decision. If a family doesn't have any children, they may ask to have a child even if he will have genetic disease. And then I think the most important part, which is the ethical background and religious background of those who are coming for consultation, because this is again a very important part that we should take in consideration. And then the last, and I think it's even a very important point that sometimes we miss, which is a long-term support, because most of these diseases, they need a long-term support, not only medical, but medical, psychosocial, and even follow-up for further counseling, and sometimes even we need to do economical support in the future. So we start with the use of family history. And family history, we do it first. We take a comprehensive family history to know the possibility of having another child, and we do what we call a family tree or a pedigree. And for the pedigree, we have we have different types, and as I said, we are going to discuss it in more details later on in the area when we have a special lecture on modes of inheritance. But here we know that it's mainly the three most important types that we meet in our counseling. It's autosomal recessive inheritance, autosomal dominant inheritance, X-linked recessive, and the X dominant, which is rare type of genetic disease. So autosomal recessive, as you can say, it's mainly goes, it's inherited in a transverse, transmission, and in these cases, positive consanguinity can carry a high possibility of getting the disease. And as I said, I'm going to cover it later on in the other presentation about modes of inheritance. And again, the autosomal dominant inheritance, which is genetic disease, is inherited in a vertical transmission from the grandfather to his kids, then to his grandsons. So this is again another way of looking at genetic disease. And then the X-linked recessive disease, which is mostly carried through a mother, carrier mother, to her male children. And I think as I said, we'll discuss it in more details in the special session about modes of inheritance. And then when we look to the recurrence risk, the single gene defects, one of the genetic counselors has constructed the family tree and established as many genotypes as possible. He is in a position to assess the risk or possibility of having another child, or even for those who are coming for counseling themselves to get the specific disease. Then we go to the other part of our presentation, which is about prenatal diagnosis and screening. If after assessing the risk of having a baby with a genetic disorder, the couple decides to go ahead and to have a baby, do we have a prenatal screening or prenatal diagnosis? Or do we have a neonatal diagnosis for such a case? All these are important points we have to cover in this. Prenatal diagnosis, we have two types, either invasive methods or non-invasive methods. These are the most common. We have others, and we'll just give highlights about them. The invasive ones like amniocentesis, chorionic villus sampling, fetal blood sampling, fetoscopy. And the non-invasive like using ultrasonography and maternal serum screening. And I want you really to put in consideration those non-invasive ones, because they are very important ones. It's easy to do in our labs. And the most common or famous one, which is a quadruple screening test or triple screening test. And the quadruple screening test it was actually conducted between 15 and 20 weeks of gestation, where we take a blood sample from the pregnant mother, and we look for 4 main components, which are alpha fetoprotein, and then human chorionic gonadotropin, unconjugated estriol, and the recent one, which is inhibition A, or inhibin A. The alpha fetoprotein alone is a very important one, because we can diagnose when it rises with neural tube defects or with third trimester complications, which is again a very important part that we can diagnose with. This will be suggestive, and then we can confirm by amniocentesis, as we will see when we discuss the invasive part. And then even we can by different variations in the levels of these 4 components that we can look for possibility of the risk of Down syndrome, trisomy 18 or triploidy, or maternal fetal bleeding, and some other disease. Then the high resolution ultrasound examination, and this is used for obstetric indication and follow-up for the fetal viability, growth, fetal anomalies. And now with the high resolution one, we started, really it became a very useful method to diagnose some of the major defects that sometimes even with the advanced type of surgery we can have an, you can say, an antenatal surgery for certain congenital heart disease or certain major defects in the urinary system or others. The best time for it is 16 to 18 weeks of gestation, and it gives us a lot about, as we say in the routine examinations first trimester, and the morphological abnormalities, it will be apparent in the second trimester, and then when we have a specialized one in the third trimester, especially with major congenital disease. Amniocentesis is the most commonly used type of antenatal diagnosis, and amniocentesis is by taking a sample of the amniotic fluid. First, we use ultrasonography to know the site of the placenta, and then we take about 15 ml of the amniotic fluid, which is containing two parts, amniotic fluid itself and fibroblasts. Then we centrifuge it and we use it to analyze it for two things. First, we use the fluid itself to look for alpha-fetoprotein, which we spoke about in the quadruple test, to look for the possibility of neural tube defects and omphalocele. So again, it's a very important part. And then the second part, to have a tissue culture for the fibroblast and having karyotype to look for chromosomal aberrations, and even for some of the errors in metabolism, especially for storage disease like Gaucher and mucolipidosis, that we can have a culture of the cells and look for accumulation of these material in the culture cells. This is for amniocentesis. And then we have a chorionic villus sampling. And a chorionic villus sampling, we use a small tube inserted transcervical. Placental cells are aspirated, and these cells used for karyotyping. At that time, we don't have an amnion to take a sampling. So chorionic villus is important because we can have a diagnosis quite early, between the week of 8 to 11 weeks of gestation. But it has a higher risk of abortion or miscarriage. It's even between 1 to 2% in the best centers. As we say in amniocentesis, the danger is much less, the possibility of miscarriage and complications are less, but we have to do it after between the 14 and 16 weeks of gestation. And then we go for a human banded karyotyping to know if we have chromosomal aberrations. We'll speak about the karyotyping in more details when we speak about chromosomal aberrations. This will be another presentation for you. Then we have new techniques for genetic diagnosis, like fluorescent in situ hybridization, which are common for fish. And then we use a special probe for certain chromosomes, and this it's useful because we can even diagnose specific genetic disease or chromosomal aberrations. And diagnosis for trismus, it's very easy to do it using this method. However, the only problem with it that it is only specific for a specific chromosomal aberration. So either for trisomy 21, 13, or 18, or X chromosome. So we have a probe for each one of these chromosomes when we go for the fish technique. And then one of the new ones, which is less invasive, or we can say not invasive, which is transcervical flushing, by identifying fetal cells in the cervix by flushing and analyze cells with fish from the flush of the cervix of the pregnant women. And then fetal cell in the maternal blood. So even fetal cells cross the placenta in a small amount, and we can sort maternal blood from fetal blood, and then we can use it for either for PCR or for fish technique. And then now with we are in the era of implantation diagnosis, and this is again we need for a pre-implantation diagnosis before putting the fertilized can say egg in the womb of the woman. We have to take a single cell from it in vitro and multiply it, and then use a fish technique or a PCR to look for any congenital anomaly before putting it in the womb of the women. So again, a very important technique that is needed these days for a lot of cases of primary or secondary sterility. And this is a fluorescence in situ hybridization in the fish technique to identify the number of chromosomes. As I said, it's specific for a specific chromosome, where we have a probe consists of a single strand DNA, which we put a fluorescent substance on it, and then we put it on the intact cells, and then we can know if we have an extra chromosome, like this case. As you see here, we have 3 spots of the chromosome, and we have only 2 from the control one, which is again one of the quick and easy method for early diagnosis. Postnatal screening, again a very important part, especially with the new postnatal screening program in Egypt, which we search for asymptomatic, early, or mild illness in a defined population. So we search in a population of a certain genotype associated with predisposing to the disease and may lead to specific disease in their offspring. So first, it's important, if we early manage, it will make a difference. So it's neonatal screening is very important. Then it's good for genetic counseling, and again for epidemiological studies. We have different type of genetic screening. We have a prenatal one, which I spoke about earlier, like maternal serum screening, like triple test or quadruple test, ultrasound sonography, and then the neonatal screening, newborn metabolic screening or other newborn screening, again even clinical screening of the newborns, and population carrier screening for high incidence of a specific genetic disease, and also for genetic counseling. So for a screening program, we have 4 main elements that we have to put in consideration. I want from you to remember these 4 main elements. First, the disease. It should be clearly defined disease, serious effect on health, treatable or preventable, and high population incidence. We have to put that in consideration and put in your mind the Egyptian program for neonatal screening where we look for hypothyroidism. We are going to speak about it later on. And then about the diagnostic test, its criteria. It should be non-invasive and easy to carry out, rapid and inexpensive, accurate and reliable. It's very important to have a highly sensitive test, which is again very important. For confirmation, it should be a highly specific test. So A high sensitive test means very low false negative cases, so we can identify all cases, including even others that they are not the disease. But for a specific test, it has a low false positive case. So if we diagnose it, that means that we are going to go for treatment, and for others we have to be sure about the diagnosis of this case. And then for the program, it's widespread with equitable distribution, so we have to give the opportunity for everybody, voluntary participation, and should be acceptable by the population, and to provide information and counseling for our can say people who go for screening. And for it we need to do three, which are the requirement for follow-up. First, we need to confirm diagnosis by reaching a definitive diagnosis. So for the screening, we just get preliminary data, and then we go for confirmatory tests. And then we have to start treatment. So treatment initiation is very essential, and then we go for genetic counseling to know the possibility of having another children or having other people with the same health problem. We do different methods for collection of data for the for screening, for newborn metabolic screening. One of them is using a dried blood, like we're using a filter paper to collect dried blood, and we have the old ones which you call the Guthrie test and Pagan test, but now we take this blood sample and we look for enzyme assay, and this is good for phenylketonuria, galactosemia, and other metabolic disease, errors of metabolism. And then we have the dried urine, and this could be good for amino acidurias and organic acid disorder. But in Egypt also, again, we look for, as we say, for phenylketonuria, which is a very important new program already started in the last 2 years to look for phenylketonuria. So neonatal screening, we take a dried blood sample on a filter paper from the hair of the infants after 3 days, between the 3rd and the 7th days after labor, and then we and sometimes you can even extend it to 2 weeks, but we have to take it after 3 days after birth to look for the level of TSH. So if the level of TSH is above the normal, so we look for T4 to confirm our diagnosis. So it's advantages of the genetic screening, especially neonatal screening. First, enhances informed choice and improved understanding, early treatment, and in the case of hypothyroidism and in the case of phenylketonuria, early treatment will have a great effect on the outcome of those patients by reducing possibility of mental retardation or all the complications of this disease, and reduction of birth problems of children. Disadvantages: pressure to participate, but I think in Egypt this is not a big problem, because most of the people, when they go for early vaccination, they go for antenatal diagnosis by taking a blood sample. And then we have a problem with the stigma of the carriers, because sometimes this may affect their social life and inappropriate anxiety in some of the carriers.